We're talking about the pathophysiology of bronchiolitis. Bronchiolitis is an inflammatory disease of the bronchioles, the lower airway, typically caused by a viral infection of RSV. It's been around a long time, but in 1841 it was actually documented and described not as RSV, but called congestive catarrhal fever. Now, catarrhal means inflammation of the nose and throat. Today, we now know it may begin with inflammation of the nose and throat, but in bronchiolitis, it is the bronchioles that are affected. So let's start there. Let's start by talking about what those bronchioles are. The bronchioles are a part of the conducting airway. It's what brings the air down to the gas exchange portion of the lung, the alveoli. The air goes through the trachea into the bronchi. The bronchi bifurcate or branch off. They become smaller and smaller. They branch down until they reach the bronchioles, which then deliver the air to the alveoli. The question is, where do the bronchi become bronchioles? What's the difference? There are some specific things that make bronchioles bronchial. Let's start with the first one, and that is the lack of cartilage. Cartilage is that semi-rigid tissue that helps maintain the shape of the bronchi, but there is none in the bronchiole. The other is the smooth muscle. In the bronchioles, there is a large amount of smooth muscle. This is one of the things that does help maintain the shape, the bands of smooth muscle. Another is the type of epithelial tissue. In the upper part of the conducting airway, in the bronchi, there is columnar type of tissue, tall, narrow types of epithelial cells. In the bronchioles, the epithelial cells are short and stubby. Now, of course, it's all epithelial respiratory tissue, which is going to be important for that RSV infection. Probably most important is the size. In the bronchioles, the diameter of the airway is very small. About 1 millimeter is the average diameter of the bronchioles. Now, you need a little bit of perspective in terms of what a millimeter is and the idea that all our air has to pass through these tiny little bronchioles. The thickness of a dime is 1.35 millimeters. So our average bronchiole is less than the thickness of a dime. It's about the thickness of an average raindrop. So again, we're talking about a very narrow passageway that all our air needs to pass through. In 1941, the viral nature of this RSV or bronchiolitis was identified, and the seasonal occurrence was described, and then in the 1960s, the RSV organism was actually isolated. This organism was placed in the paramyxovirus family. This organism, RSV, is in this family along with measles, mumps, parainfluenza, and in fact, paramyxo comes from the Greek words meaning beyond slime or mucus. And if you've taken care of children with bronchiolitis, you know they have a lot of mucus production, and so it seems appropriate that it is in this family of viruses. Now, of course, we do make antibodies to this viral organism, and this is evidenced by the fact that secondary infections, the second time someone gets infected with this organism, it is less severe. And also, babies have a much more severe illness. In fact, preterm babies often have a much more severe infection with RSV because they don't receive the transfer of transplacental antibodies that occur late in pregnancy. Other babies are also at high risk for RSV infection. Those babies include infants that are born between April and September, because those infants will be aged 2 to 6 months during the winter months. Infants with school-age siblings, because they may be carrying the RSV infection. Infants who are in daycare or live in crowded conditions because of the transfer of the RSV organism. And infants exposed to passive cigarette smoke. So let's take a look at that RSV organism. It's a single-stranded RNA virus, and its genome encodes for about 11 different proteins, 2 of which I'd like to start talking about because they're actually on the surface of the RSV organism. The first one is the G protein. That G protein actually encodes for the different strains of RSV. The 2 main strains are A and B. A is the more serious one. It causes more serious infections. In fact, it accounts for about 90% of the pneumonias that we see in little infants and 80 to 90% of the bronchiolitises that are seen in infants. The F protein that's on the outside of that RSV is also very important and stands for the fusion protein. It is what makes the RSV adhere to that epithelial, cuboidal, and columnar tissue inside that respiratory tract. Not only does it adhere to the epithelial tissue, but it makes, once it gets inside that epithelial tissue and begins to replicate, it then makes one epithelial cell stick to the next epithelial cell. This does 2 things. One, it creates those syncytiums, hence giving RSV its name, respiratory syncytial virus. A syncytium is a group of cells. The other thing that it does, it allows the RSV organism to move down that respiratory tract. An infant typically begins with an upper respiratory tract infection, and then within 1 to 3 days we begin to see symptoms of a lower respiratory tract infection. It begins to infect the epithelial cells of the bronchioles or even the alveoli. Once it infects the epithelial cells, and it replicates within those epithelial cells, those cells die. And as they die, they slough off into the lumen of that airway. Now, if it's a big lumen or passageway, it's more likely that the individual is able to clear or move that debris out of the airway. But in that tiny bronchiole, that debris causes inflammation. So we have cellular debris, we have mucus, we have edema of the cells. This irritates the airway. This irritation causes bronchospasm. Remember that smooth muscle on the outside, that is the hallmark of the bronchiole, contracts and causes bronchospasm. Now we have 3 things that are happening. We have bronchospasm, edema of the epithelial tissue that is lining the inside of the bronchiole, and mucus trapping. This should sound like another condition that you may be familiar with, and that is asthma. But remember, asthma is a chronic recurring condition. RSV is an infection that results with these same types of responses in the bronchioles. So, what then happens in terms of gas exchange, in terms of the airway? We have what's called ventilation perfusion mismatching because of these 3 physiologic responses. Air becomes trapped in the alveoli. When the bronchiole becomes inflamed, air gets trapped in the alveoli and the alveoli becomes over-distended. That's one thing that can happen. The other thing that can happen, an nearby in the same lung is that we have collapse of other alveoli. So in some areas, we have alveoli that are stretched out and over-distended, and in other areas, we have alveoli that totally collapse down and there's no air in them. These are different forms of ventilation perfusion mismatching. This VQ mismatching causes hypoxemia and the manifestations of bronchiolitis. RSV bronchiolitis is a viral infection of the bronchioles. RSV is a virus that has a special affinity for the epithelial cells of the respiratory tract. Once those epithelial cells are infected, they replicate within the epithelial cells, cause cell death, airway inflammation, and obstruction. If the obstruction is in the bronchioles, again, it's called bronchiolitis, results in VQ mismatch, hypoxemia. If you want to know what to do about it, stay tuned to learn more about the management of RSV bronchiolitis.